I'd like to introduce Rob. Rob Entrekin is a senior clinical scientist in our ultrasound team, and he's going to share with you couple technologies or ways to really look at identifying the plaque burden earlier in coronary artery disease patients. So, Rob?
Thank you, Lori. I'm a biomedical engineer by training, and in fact, Dr. Patel, I did my graduate work at Duke University with the BME department on the first cardiac phased array scanner with Joe Kislow. So I have a soft spot in my heart for Duke. I am a clinical scientist, as Lori mentioned, in Philips Ultrasound in Seattle. And my colleagues who are also on the call today are Antoine Collet-Bion and Laurence Rouet, and they're both senior scientists at Philips Research, located in Paris. I'd like to talk to you today about 3 concepts for how ultrasound might contribute to earlier detection and improved risk stratification for coronary artery disease, and get your thoughts and feedback. As we all know, atherosclerosis is a progressive and systemic disease that affects all major arterial territories, but coronary atherosclerosis is the most significant because it's the largest cause of morbidity and mortality worldwide. The most accurate methods for diagnosing the extent and severity of CAD are usually indicated only after a patient becomes symptomatic or has a major cardiovascular event. So the challenge for primary prevention has always been to find a non-invasive and accurate method to identify asymptomatic patients at high risk, so that early intervention and treatment can prevent that first heart attack before it occurs. Many studies over the past 20 years have shown that ultrasound can detect and quantify subclinical plaque in the carotid and femoral arteries, and that this peripheral plaque burden is an independent risk factor that's predictive for CAD and major events. The evidence for this is sufficiently strong that several medical societies, especially the European Society of Cardiology, have adopted clinical practice guidelines that recommend ultrasound for the assessment of carotid or femoral plaque as a risk modifier in patients who have certain comorbidities such as hypercholesterolemia or diabetes. So at Philips, we ask ourselves, how could ultrasound be used to implement these guidelines and help improve early detection and risk stratification for CAD? We've been exploring 3 concepts. The first idea is to use point-of-care ultrasound in an office-based setting for early detection of carotid plaque as a biomarker for CAD risk. The second idea is to use 3D ultrasound for precise quantification of peripheral plaque burden for better risk stratification. And the third idea is to use artificial intelligence to analyze 3D images and classify plaque composition with a kind of ultrasound virtual histology. So let me explain a little bit more about each one of these ideas. In the first concept, the cardiologist or nurse would examine the carotid arteries in an office setting with a handheld ultrasound like the Philips Lumify in order to screen for the presence or absence of carotid plaque. I should point out that this would not be a conventional vascular exam with dozens of annotated images and Doppler measurements. This would just be a simple survey sweep of the carotid from clavicle to jaw, recorded over 5 or 10 seconds. My colleagues at Philips Research have been developing AI-enabled image processing software that can automatically identify the artery wall and plaque in each frame and measure the maximum plaque thickness in that segment of the artery. A study published in 2018 in the European Heart Journal by Sillison showed that in a cohort of 5,800 asymptomatic American adults, a maximum carotid plaque thickness greater than 2.5 millimeters predicted future cardiovascular events at a rate that was 3 times higher than those with no plaque. Also, in a 2019 Lancet article, Naslund reported on a study of 3,500 Swedish adults with 1 or more conventional risk factors. They demonstrated that just showing the patient a picture of their carotid plaque improved patient compliance with lifestyle modification and medication, and significantly reduced their Framingham risk score at 1-year follow-up. So we think this simple office-based approach could be beneficial for identifying patients at higher risk for CAD and for helping them modify their risk factors. In 2019, Philips developed a 3D vascular transducer for the Epic Elite ultrasound system. This fully electronic matrix transducer captures a volume snapshot of the iliofemoral or carotid bifurcation in a fraction of a second. And this 3D snapshot, along with some deep learning software, can reconstruct a geometrically accurate 3D model and precisely quantify the plaque volume in the region around the bifurcation. Another study published in JACC in 2015 by Fuster showed that in a cohort of 6,000 asymptomatic American adults, both coronary calcium score and carotid plaque burden were equally predictive for major cardiovascular events in a 3-year follow-up. So we think that quantification of plaque burden with 3D ultrasound can provide useful information for predicting cardiovascular risk. In the third concept, we're using deep learning algorithms and training them to analyze the grayscale statistics and texture of the echoes from inside the plaque in order to classify its composition. Previous studies have shown that echogenic carotid plaques are associated with stable components like calcium and fibrous tissue, while echolucent plaques are associated with unstable components like lipid-rich necrotic core and intraplaque hemorrhage. So if we're successful, this virtual histology approach could be used, for example, for monitoring changes in plaque composition in response to lipid-lowering therapy with statins, PCSK9 inhibitors, and other drugs. So at this point, I'm happy to answer any questions you might have, and I also have some questions for you.
Well, I think that this system where you can use it in practice, point of care setting is extremely useful. And I'm impressed by the study, and I was an editor of the European Heart Journal at that time, that shows actually how it can have an impact for patient compliance, for patient understanding of the disease process. And I would certainly say that pictures say more than 1,000 words, as the Chinese said. And insofar, that's very, very interesting. And of course, the other system is more for research purposes, I guess. In clinical setting, you're not that interested in such a precision because the management that is derived from is usually quite standard, independent on this deep insight into the structure, but for academic purposes, extremely interesting.